surgeons have kind of a bad rap, but I think in respect to endometriosis surgery, excision surgeons really need to be acknowledged, and we need to find more of them to help patients to know that this is something that they need to do. I wonder, with respect to our evolution and how many women probably have this. Every time I'm on Instagram and I see 1 in 10 women have endo, I feel like there's probably so many more. I feel like 9 out of 10 women probably have endometriosis to some extent. What do you think?
No, I don't know that it's necessarily that prevalent. I think it's probably more prevalent than the 1 in 10. Because when you look at some of the other statistics, for example, in the realm of of unexplained infertility, and the statistics are staggering. It's somewhere in the neighborhood of 50+% of women with unexplained infertility, and for our audience, unexplained infertility are patients who have the $1 million workup and everything comes back normal, but they're still not getting pregnant.
And they've been trying for 2 years.
Right. Or they get pregnant and they keep miscarrying. Nearly, half or more of those patients have endometriosis. The problem among physicians is that they are locked into this very old school mentality of, well, you don't have the classical symptoms of endometriosis, so you probably don't have it. And that's unfortunately not true. It's not a condition that you can relate typical findings or typical symptoms to, like other medical conditions, like appendicitis or cholecystitis or anything like that, where you have triads of symptoms and classical findings, et cetera, and so forth. And speaking from over 2 decades of experience, I can tell you that patients are always telling me, like, what's the likelihood you're going to find endometriosis when you operate on me? How much do you think I have? And I can speculate, but I'm constantly surprised. I put the camera in on patients who I think are going to have minimal disease, and they have quite a bit, and vice versa, and everything in between. And in the realm, going back to the unexplained infertility patients, so many of them are like, I don't really have much in the way of symptoms, but what I find in my personal experience, which can't be unusual or individual, is that when you sit, and this is something else that I'm very keen on, when you actually sit and get a thorough history from people, you find out a lot more information than they were really aware of, or that any other clinician really bothered to find out.
To ask.
And it's because people think that certain symptoms are normal, just because it's come upon them so gradually, and it's kind of part of their life, and they think that having debilitating periods is part of growing up, and they've been told this by hospital nurses and pediatricians and the student health office at college and what have you, and it's not normal, and that's one of the things that I always tell people, like, debilitating periods are not normal. I mean, yeah, you may have some pain, you may need to use a heating pad for a little bit or take a Tylenol or a Motrin, but it shouldn't be to the point that you can't go to school, you can't go to work, and you're curled up in a ball in your bed or in the corner of the room, or sitting in a hot bathtub for 6 hours. That's just not normal. Mm-hmm. And then when you piece this all together, and they're like, oh, I thought this was normal, I thought that was normal, and like, it's not normal. And the abdominal pain that you have every month, and the motility problems that you have, and food sensitivities, and all this thing that you've been living with since childhood, that's all abnormal. And then you operate on them and you find disease. And then it's eye-opening for the patient. And it's very critical for reproductive endocrinologists also to acknowledge. And many of them do, but there's still some who don't. And they have a philosophy of trying to power through the endometriosis rather than treat it.
Or send them on an IVF with ICSI route, and that's
Right.
going to save everything.
Right.
Or put a month or 2 of Depo-Lupron into the mix.
A lot of times it requires the mental fortitude to stop, take 2 steps back, and really reevaluate, and not keep doing the same thing, because the old adage, and if you keep doing the same thing and you expect a different outcome, that's the definition of insanity. And it's true.
Yeah, I try to help my patients focus beyond baby making. Would you like to not have debilitating pain,
Right.
bloating every day, and painful sex?
And I tell people many times, even patients who aren't really interested in fertility per se, it's an issue that will, if you treat it, will open up many avenues, because it will, for some people the critical element is quality of life, and for some people it's fertility. But in reality, yeah, you want to feel better, but down the road you open up the option of childbearing if that's something that you desire.
Mm-hmm. I had to convince my surgeon in 2005 to do surgery. He didn't want to do it because I wasn't in a relationship. I wasn't actively trying to conceive. And I had to say, I miss work, I vomit.
Right.
And I'm almost fainting because the pain is so bad. I learned that my cervix was stenosed, and so blood clots couldn't pass, and that was what was making me faint. I'd have to be taken to his office on day 1 of my cycle. He'd use a Q-tip and pull those blood clots out so that then I could go back to work. That was extreme. And so I said, forget about me trying to make a baby. That's not where I'm at. This is no way for me to live. It's important. So then
and it's and the other, that's another common fallacy, is like, oh, don't treat it until you want to get pregnant, which makes no sense, because it's a progressive condition. Why wouldn't you want to remove disease in its earlier stages, then wait until it's more advanced and deeply infiltrating and causing more, not only symptoms, but it also causes anatomic distortion and destruction of tissue. And as an addendum to that, the old school mentality was, don't treat it when people are young, wait until they're older and of childbearing age. But what we've now discovered is that you can find just as advanced disease in teens and adolescents, and they can be just as affected at 14, 15, or 16 as someone could be at 26 or 36. And I have quite a few patients their mothers are my patients, and because they're more sensitive to the symptoms of endometriosis, they see themselves and their daughters as they're growing up, and they're following the same patterns. They recognize it early, and they're like, I don't want her to suffer the way I did until I was 35 and like unable to conceive. And then all of a sudden I was diagnosed and had surgery, and then thank God was able to conceive and like move on with my life. Why wait another 20 years? Let's treat it now. Mm-hmm. And it makes a lot of sense, because it's also not had all those years to inflict its effect on all other different organ systems, and it's much more difficult to undo a lot of these issues when they've been going on for 10, 15, 20 plus years. Mm-hmm. So why not treat it early on, nip it in the bud, so to speak, mm-hmm. and let someone, take the more pleasant path in life from mm-hmm. an earlier age.
And if we're talking about fertility, it would be good to take care of that earlier on for
sure.
the egg reserve.
For sure.
You can preserve more of their fertility. I think it begs the question of what exactly are we dealing with as the conversation keeps is out there of, it's retrograde menstruation. No, it's undifferentiated embryological tissue. And I'm thinking it's sugar and inflammation from our diets. And then, as we were talking before the interview, microplastics. So like it's a combination of different things, or is it undifferentiated embryological tissue?
Dr. Redwine was really key in theorizing and identifying the etiologic nature of endometriosis.